Hi, everyone. Welcome to the Superfeeler podcast. My name is Laurie, and I'm super excited today to be joined by Dr. Shirley Yen, who is from the Harvard Medical School and has done a whole bunch of really cool research, not just around personality disorders, but also people who live with psychosis, suicidality, bipolar. Correct me if I'm wrong on any of those things, but I think that's correct. And we're actually going to be speaking at a congress in November in Boston together.
That's right.
Talking about resilience. So I'm so excited about that. We can talk a little bit more about the Congress later, but just do you want to introduce yourself and what you do?
Sure. First of all, thank you so much, Laurie, for inviting me. So I have to say this is my first podcast, so exciting. So I'm a clinical psychologist by training. So I have my PhD in clinical psychology. I wear actually several different hats. So I am primarily a research psychologist, and most of my work is focused on suicide prevention. I'm also a director of psychology trainings. I am the director of a clinical psychology internship program at Massachusetts Mental Health Center. I'm a licensed psychologist, so I see a few patients. I also hold some leadership positions in professional organizations, such as the International Society for the Study of Personality Disorders, the Congress that you had just been speaking about. But I think my main passion right now, and I think the topic of our conversation, is in developing and testing resilience and strength-based interventions for teens and young adults who are struggling with depression and suicidal behaviors.
Yeah, that's amazing because as a person who struggled with mental health since I was a child, essentially, and had a lot of symptoms of things like borderline personality disorder from really early ages, it's just like not addressed very well, or at least when I was that age, which to be fair was 20 years ago. But I'm so happy to see that there's dedicated research on suicidality in teens because I heard, I don't know about in the States, but I heard at a conference that I was at yesterday that suicide is the number 2 leading cause of death in Canada for people 10 to 18 or 19. So sad.
That is true for the States as well. Yes. In fact, it's surpassed accidental deaths as a leading cause of death.
Which is awful. So do you feel like that's changed since COVID because of isolation? I really do worry about kids. I see my niece and nephew who are COVID babies, and I'm like, wow, they've just like lost so much. And I worry for their mental health in the next 10 years.
You know, this trend towards, I think, a decline in the mental health of adolescents. And I speak about this globally, right? Because there are teens that are thriving. Clearly, right? But I do think that we have, in the US, the Surgeon General has called it an epidemic of, we have a teen mental health crisis. I do think that it's been exacerbated by COVID, and so much has been taken away from them during these critical learning years, especially learning about social engagement. I think we have a loneliness pandemic.
Yeah.
I also think that this trend has started prior to COVID. A lot of people blame social media as one of the factors. There are probably others as well.
Yeah, totally. I mean, I can't even imagine growing up with a cell phone that did all the stuff that it does now. That it would have completely changed how I was developing, for sure. So what brought you to wanting to study adolescents who are struggling with suicide and mental health?
Well, it's a funny question. Well, first, I once told myself that this is after working with teens for 2 years in a residential treatment program. I actually once told myself, I'm never working with teens.
Fair.
But yeah, here I am. And I will sort of describe how that happened. But I think the first question, I think my first passion was actually to study suicide. And I think there's an expression in our field that research is me-search. Right.
Yeah.
And so I'm sure you've heard that. So actually, my family history includes several suicide deaths that all happened before I was born. But I think the story of their deaths and how they chose to take their life to escape political persecution. I mean, this is during the time of the Cultural Revolution. Those stories really remain with me, especially as I got to know some of my uncles who did survive.
Right.
I mean, they they survived through terrible, devastating hardships of being separated from the families and living and these work camps and not knowing what they would have to go back to if they could ever go back. So it was horrendous hardships. But seeing that some survived and some not only survived, but really were able to flourish, have families and have a really meaningful, productive career. And it really sort of planted those early questions in my mind of why do some people die by suicide and of those survive, why do some seem to why do people have different outcomes?
Yeah, especially when they're related, because presumably they had similar upbringings, and
exactly.
Yet one went one direction and the other went the other.
Right, exactly. And so for me, because it was sort of family that was that I didn't I knew the surviving uncles, but I didn't know those who died by suicide. I think I had a lot of curiosity and enough emotional distance to be able to really fully immerse with this at a professional level. And then when I went to graduate school, I had the good fortune of working on sort of this unique longitudinal data set called UNC Alumni Heart Study, where they actually collected personality profiles of incoming freshmen at UNC Chapel Hill. This is in the late 60s. And they did the MMPI. And then they follow them annually on a number of health metrics. And this is also a famous study that yielded sort of the groundbreaking research that hostility and type A personality is linked to coronary heart disease. But I decided I wanted to sort of use this data set to look at personality profiles associated with those who had died by suicide in this data set, which is sort of a unique opportunity to sort of get this perspective information.
And have they been following that same group for 60 years now?
This was a while ago when I was in graduate school, but they had been following them for decades, right?
Amazing.
So we were doing things like collecting death certificates. And so it was kind of a very unique data set. And from there, one of the findings that I found was compared to those who died by other causes, those who died by suicide had endorsed significantly more social introversion and self-blame, when they were in college. And so, from there, I just sort of, I really grew to the concept of wanting to look at perspective predictors, worked on the collaborative longitudinal study of personality disorders. And that's where, in interviewing a lot of people, and we generated a lot of papers from the clips that are all published online, but that's where I really started to become interested in adolescence again, because in interviewing the study participants or listening to their stories, these patterns always started in adolescence or childhood.
Yeah.
And also in doing the research, I realized if you're a clinician, it's really of limited use to know who is at high risk. The question that clinicians are often wondering is, when is someone at high risk? What do I do?
What do I do about it? Yeah.
What do I do about it? And when are they? Exactly. Both of those things. So that's when my research kind of shifted towards working with adolescents and wanting to sort of do interventions that could sort of help in real time.
Right. So for so many mental illnesses, borderline personality disorder included, you do see those things from earlier on. For psychosis, though, which you've done some study on, that would often show up kind of early 20s-ish. So, or do you see the precursors way earlier and people just don't talk about them?
I think that you see the precursors earlier, but they might look different. I think that, and it might not manifest in suicidal or self-injurious behavior, but I think that you might see some social isolation or some cognitive indicators of, possible paranoia or delusions or things like that. I think that, yes, with psychosis spectrum disorders, all these disorders are different. They have different levels of contributions from, genetics to neurobiology to environmental factors and trauma and things like that. And so I think each of these disorders have sort of different amounts of these contribute differently to the etiology of the disorder. And I think with psychosis, it really is, I think that what you often see in teens is sort of this undifferentiated set of problems that
Right.
sometimes it is very hard to know. Is this emerging bipolar, emerging schizophrenia, emerging something else?
Right.
Right. So you often see these things that are kind of undifferentiated, like emotion dysregulation, extreme dysregulation, or thoughts of self-harm as a way of wanting to regulate these
Totally.
very strong emotions, right? And you might have some cognitive, aspects, or social isolation, or other ways of sort of other, I guess, impairments.
Mm-hmm.
Oftentimes, it's not really clear what the trajectory is until
You know
you
they're
get
at
past 18.
higher risk, but not sure of what
Exactly.
necessarily.
Exactly.
So do you look at adverse childhood experiences in your research?
Absolutely.
Okay,
Yeah.
because that's
Um,
fascinating work.
yeah. Yes. And we've published a number of studies on that, and not surprisingly, I think those with borderline personality disorders report experiences of childhood sexual and physical abuse at much higher rates than
Right.
other disorders. Yeah.
Yeah. You're talking about self-harm and you said, to regulate emotions. And I think that why, quote unquote, why do people self-harm is such a common question for that I get asked, that I know I get asked by parents and clinicians and all sorts of people. Do
Hmm.
you have a thought on why people do that?
I think that's an excellent question, right? That's in some ways the $1 million question, right?
Mm-hmm.
I think that there's a lot of different reasons. People do it for different reasons.
Mm-hmm.
And I think, part of the problem, I think, is when we sort of make assumptions that most people who have borderline personality disorder might do it for X, Y, and Z, and we sort of impose that assumption. So one of the things that, as a training director, I often advocate is always understand that individual story first,
Mm-hmm.
because it is very idiographic and personal, and you'd be surprised at what you might find.
Yeah.
I think some common reasons are to, of course, stop the pain,
Yeah.
right? And I want to make
Which
a
always seems
distinction.
ironic for people that have never self-harmed, right? They're like, what do you mean
Hmm.
stop the pain? Isn't that painful?
Right,
And you're like,
right,
yeah, but it stops the emotional pain.
right. And I think that, and I'll talk a little bit about the distinction between suicidal or suicidal behaviors, which involves
Mm-hmm.
this intent to die, versus non-suicidal self-injury, which often they often get conflated because
Totally.
there are overlapping risk factors, and people from the outside see these as similar behaviors,
Yeah, they think
right?
that if you self-harm, you're trying to
Right.
die. And that's very much not the
That's
case for a lot of
that's
people.
very not the case. Now, there's sometimes we do hear reports of when I started, it was not with any
Mm-hmm.
intent, but then during the process, I did wonder,
Interesting.
might it be bad? So, it's blurry, but for the most part, they're different behaviors. And so, in terms of NSSI and why people do that, I think part of it, as the most common reason that I hear is to stop the emotional pain by giving yourself something physical to focus on, actually distracts from the emotional pain. For some people, there is a physiological effect
Mm.
of
Like an
that
adrenaline
pain
rush kind of thing.
releases endorphins.
Right.
Exactly. In some teens or young adults, and usually these behaviors do burn out sort of
Mm-hmm.
in adulthood. But when we talk to teens or young adults who do it, sometimes it's almost described as an addictive quality,
Totally. Yeah.
right? And then for some people, there might be social reasons for doing it,
Yeah.
whether it is in some way to influence their social environment through attention or a means of trying
Communication.
to communicate their
Yeah.
need for help. So it really varies quite a bit. But those are some
Totally.
common reasons.
Yeah, no, that's great because that's usually what I say too. So I'm glad that we're on the same page there. The attention one is so tough, right? Because people with
Hmm.
BPD are often criticized for being manipulative and attention seeking. Okay, but also if they need attention, why don't we try giving them attention and validation and see if that helps? Because sometimes you can't express
Exactly.
what you need with your
Right.
words. Yeah.
Exactly. I think that's a great example of how sometimes when, especially with borderline personality disorder, that people often sort of think they're doing this for attention
Hmm.
without really understanding the individual, circumstances and motivations. And you're absolutely right. Even if you think it's attention, let's help that person put words to their emotions.
Yes.
And let's help that person. Let's say, if this is what we suspect is going on,
Hmm.
then we need to help you be able to talk more effectively about your emotions in a safer manner.
Yeah, and find less harmful ways to get that distraction, get that endorphin
Hmm.
release, and
Exactly.
yeah, communicate. So, as a psychologist, what's your general modality that you use? Or do you have one?
So that's a great question. So, in terms of modality, my general principle is that I am not deeply wedded to any one modality because I really, really strongly believe that as a therapist, we need to first assess and ascertain where your client or patient is at and what they need. And I firmly believe that different people might need different modalities at different times of their life. Right.
Totally.
So I think, in terms of modality, I am DBT trained and I really am a strong advocate of DBT. I love the principles of DBT and I find myself referring
Hmm.
back to the concept of dialectics all the time. I'm a big fan of acceptance based interventions as well. And my own intervention, I think, is rooted in sort of this third wave acceptance based modality. But I'm also a big advocate and champion of psychodynamic
Okay.
modalities. I think especially for individuals who've struggled with symptoms of personality disorders, because a lot of these do come from some difficult early dynamics and relationships. And I think that, I have a very strong relational leaning.
Right.
And so I think that psychodynamic therapy, I think really is I think it's a very useful lens.
Right. And a less manualized approach so you can
And
adapt it
exactly,
better. Yeah,
exactly,
that
exactly.
makes sense. So, do you want to talk about the intervention that you've developed?
Sure. So, I think that, and you'll be
Talking
hearing
about
more
this.
about this,
Yes.
at the Congress. But so basically, where I want to start is, we'll be talking about sort of we'll be presenting within this
Hmm.
umbrella of resilience-based intervention. And, I think I do want to take a step back and talk about sort of, what does resilience-based mean and what does
Hmm.
strength-based mean? So I think that first, I think one of the problems, I think, of the existing sort of sets of interventions that we do have that target suicidality, whether it's in teens or adults, is that they're often deficit based. They
Yeah,
focus
totally.
on what are the problems, what could you be doing better. It's deficit focused, and that's important. I'm not saying that that's not important.
Yeah, we're not trying to ignore that there's bad things happening, which I think is
Exactly.
a misnomer for a lot of people.
Exactly. We cannot ignore that, right? And there is absolutely very useful space for that because I think not coping with things in the most effective way will beget more problems, right? So I think that is an important focus. But I do think that we miss the other end, which is sort of a more resilience based focus and space focus. And I sort of see this as, these two things have to be sort of in equipoise with one another, right? So, in terms of my intervention, I'm not advocating this as a primary psychotherapeutic approach. I'm advocating this as adjunctive. And it's an approach that should not interfere with any other therapy that you're getting, that individual therapy, which is so needed to talk about your unique challenges that you're confronting right now. So in terms of, the resilience-based interventions, I think that a lot of another problem that I had seen in the literature, and I became interested in this actually through my own research where I followed teens who were admitted to the inpatient unit for suicide attempt or behavior. I followed them for 6 months and looked at what are the predictors of future attempts. And I found that low positive affect was one of like the most robust predictors. And I was curious about, okay, well, let me look into positive psychology interventions. A lot of them came from the CBT tradition and focused on change. And I think that to what we were to the point that I was making earlier, I think, change sometimes feels so hard and out of reach for people who are in the depths of despair.
Mm-hmm.
And so I wanted to sort of try to come up with something that was a little bit more feasible, for manageable for people when they are in their depths of despair. And I want to talk a little bit about sort of this, you and I had this conversation about the word resilience.
Yeah.
And yeah, I know that resilience there's been some resistance to that word, and it's had some negative connotations because it kind of places the onus on the individual
Mm-hmm.
rather than the societal and external factors, which are very hard to, sometimes very hard to change.
Or impossible to change, like
Or
race,
impossible
right?
to change, exactly.
Yeah.
And so I think part of it is that I think when we talk about strengths based, everybody has strengths, right? I think the difference between strengths based and resilience based is resilience based implies that there's some adversity that you're bouncing back from. So resilience based also encompasses strength based. And I think that my focus on resilience comes from the place that I think everybody has strengths and everybody has some measure of resilience that we end up exercising every single day. Now, there's a lot of individual variability to that. So some people are forced to exercise their resilience a lot more than other people are.
Mm-hmm.
And whether that might be due to factors from systemic oppression or being stuck in toxic or abusive environments. Like a lot of teens are often invalidated in their home environment and they don't have the means to change that. None of that is fair, right? And there's a lot of individual variability to that. But we all have some level of resilience. And I think our co-presenter, Isabel Glass, I'm going to give her a shout out. She framed resilience as, well, you can think about it as a trait, which is true that different people have different, I think, levels of that ability to bounce back, right? And we don't know why that is. That could be due to a number of factors. But it's also a process. Resilience is a process. It's a process that we have to engage in every day. And it's a process that might entail using sort of the individual skills and strategies that we've learned from therapy or from other friends or just living, right? And it's a process of reaching out to supportive others, engaging or being involved in your community, of reaching out. So that resilience is also a process.
Mm-hmm.
So I think, I understand the critiques about resilience because it comes from a place of fatigue. People are tired of fighting sometimes the same fight all the time, right?
Mm-hmm.
Tired of fighting against things that are just not in their control and just not fair. And I want to acknowledge that we are all resilient and we're all practicing that every single day.
Yeah. Yeah, first of all, our presentation, I think, is going to be really great because I think all of our work really aligns well with each other. Isabel talking about the differences between grit and resilience, which I thought was fascinating. And we don't want to spoil alert.
Mm-hmm.
We'll let her share at the Congress about that. But I was just fascinated. And then Mary Zanarini, when I got on the call, I was like, I've been citing this woman for 15 years. I was like, I could not believe. She's done so much incredible work in the field. I truly was blown away. I could have, I could have started crying. I didn't, but I could have.
Yeah.
And then the work that I do is so focused on peer support and just building community that's focused on highlighting the strengths of having strong emotions. And I know sometimes I have a very funny, I might make a slide of it because it's like a 1 minute clip of a person who's a regular contributor on this podcast who talks about how I used to talk about, like, I love having BPD. It makes me the person that I am. And I think there's so many positives about it.
When I first started listening to your original podcast, I would get a little irked when you would be like, I love having BPD. I would never change it. And I'm like, I would kill 3 people. Not really, but like it was that strong that I'm like, I would go
Allegedly
through fire for this. But like now it's only like a year later and I wouldn't trade it for the world, because now that I can manage some of my symptoms, I'm freaking cool. And like, I wouldn't be nearly as like excited about things that other people don't get excited about. I wouldn't be as funny as I am. And like it just really makes, like, I wouldn't be me without it. So no, I wouldn't take it away now.
And a year later, she also believes that like there's so many strengths in this diagnosis and she absolutely loves it. There's obviously hard times, but there's so much positive if you can harness those emotions for things that are helpful in your life and bring joy and community, right?
That is exactly right. And that's also why, early in my career, I started working with people with borderline personality disorder because I could see that strength.
Yeah.
That emotionality is also such a powerful harness for activating and for doing great things and for being great partners, family members, parents, friends. Right.
Totally.
So there is, I think it often is about, so, in terms of my intervention, it is about sort of some psychoeducation to acknowledge that it's not an either or, right? And this comes from sort of DBT.
Yeah.
That to sort of identify what are your strengths. And also, I think often, well, I guess, when I think about, what might make my intervention a little bit different than sort of the positive psychology interventions that are out there. I've already talked about sort of the focus on acceptance. And that's exactly, accept the things that make you who you are.
Yeah.
Find strength in that and amplify that. But I think the other more critical way is, rather than relying on some strategies for change, my intervention looks at attention as your most valuable resource, right?
Like what you provide your attention to?
What you provide your attention to, right? And I think that understanding that we've actually evolved, right, to have biases towards attending to negative things.
Right, totally.
Things that are potentially threatening in our environment, right? And now they might be, well, most likely they are not the life and threat, situations that we have evolved from.
Yeah.
But they can feel that way, right?
And they do better on social media too, right? The negatives bring people in. So then that's all you're seeing. So of course your mind is going to automatically go to that.
Right. It hooks your attention for a very important evolutionary reason, where we have also evolved to have positive emotions. And there's a whole bunch of research to indicate why that's important for survival as well. They do these great fancy social psychology experiments where they induce positive emotions in laboratories. And they find that that people who've had those inductions, they tend to be better at problem solving. They tend to be more creative. They rate their relationships as closer. And so, inducing positive emotions, this is the equipoise, that can kind of build the resources that you need to be resilient, right? So the intervention that I have leans a lot more on, how do you deploy your resources? What are some exercises to sort of get you to be mindful of the things that you're grateful for or to savor? So the exercises are actually very basic and not that innovative. I think it's the way we understand.
Right. The refocus.
What resources, the refocus that, yeah.
That's so cool. Oh, amazing. Well, I'm so excited to learn more about it at the Congress. So just so people know and they can search for it, obviously I'll put the links in the chat, but it's the International Society of the Study of Personality Disorders Congress. It's in Boston in November 9th to 11th.
9th to 11th, yes. really excited
Right
about
now,
that.
there's a code flash. I'll put this in the show notes, but flash ISSPD for 10% off registration. And they just are announcing that there's going to be a hybrid option. So for those who
Yes.
can't attend for a variety of reasons, you can still see most of the you can see all of the
Some.
main presentations and then some of the
Yeah.
other presentations, not
Yeah.
ours, unfortunately, which is too bad.
Yeah. Right. But you're learning a lot about it from this
Yeah.
podcast. So
Yeah, exactly. So you've been to congresses before, I'm assuming, with
Mhm.
ISSPD? What's your favorite part? Why should people go?
So what I think there's a lot of reasons to go to conferences in general. I think, and some of the reasons why I hope that people go to ISSPD are similar to why we go to conferences, right? It's really about the networking and just I love seeing colleagues in person, right? And having those side conversations that surprise you and you don't know where it goes. And I feel like, after every congress or conference, I often come back with, all these great ideas and potential collaborations. And I think it's an opportunity to just learn more about personality disorders from a wide range of experts. So we have people who are researchers. We have people who are clinicians. We have people who with lived experience. We have people who are carers, and we have people from outside who are not experts in personality disorders, but bring in a different type of expertise.
Mm-hmm.
And I think that's what makes it really rich is when you can sort of cross pollinate these sort of different types of experiences that you have and knowledge that you have.
And what's really great about it is that it's not just about borderline personality disorder, it's about
Right.
all personality disorders, which truthfully,
Exactly.
that's one of the things that I'm the most excited about because there's so many personality disorders that do not get attention or are even more misunderstood than BPD.
That's absolutely right. In fact, when I was president of NASPD, the North American Society of State Personality Disorders, and we had our Congress, that was something that we had struggled with is that most of the work and research is dedicated to borderline personality disorder. But the other personality disorders, even if they're not the main disorder, bring patients to offices or to
Right.
EDs, they have a significant impact on the care they receive, not just psychiatric care, but even medical care, right?
Yeah. Well, there's no way to even separate those two things, honestly.
Right, exactly.
Yeah.
So yeah, I think that I'm excited for that as well. I think there's a lot of feature presentations this year on narcissistic personality disorder, which I think is definitely a growing interest in the public sector. And, I think it'll be great.
Yeah, I'm interviewing next week Elsa, who all of her research is about narcissistic personality disorder or narcissism as a concept. And I have so many questions. I could literally probably ask her 100,000 questions because it's an area that I really don't understand. And I've obviously dedicated my life and career to BPD because that's what I live with and that's kind of my niche. But there's also a lot of stigma in the BPD community against people who have narcissism. And I want to be able to contradict that and say, hey, these people are struggling too. But because it's so hard to find people who have narcissistic personality disorder that are open about it, it becomes like this slippery slope of they're more and more hidden because they don't want to talk about it. It's really tough.
Yeah. You've brought up an excellent point about the need for destigmatization, which, I wholeheartedly endorse. And I think that, you're probably familiar with this, the long road in BPD, and we're not even fully there yet.
No, but
it
is
close.
improving.
But it is improving. There's a lot more attention on this. Yeah, that's been one of my pet peeves about a lot of the current diagnostic system.
Yeah.
And sort of the need to invent disorders of emotional regulation for, children and teens because, they can't possibly have borderline personality disorder or traits, or we don't want to say that they do.
Yeah.
I think it just muddies everything.
It does. And then I'm also the kind of person who I look back at my psych records from when I was like 10, and it's so clear that what I was struggling with was BPD, and I
Yeah.
didn't get diagnosed till I was 18.
Yeah.
And so I didn't get
Exactly.
treated until I was 18. And so to
Right.
me, it's hard because you don't want to over pathologize,
Mhm.
but sometimes naming something can then lead to the treatment.
Absolutely. And I think if I wasn't clear before, I think what I was advocating for is that let's not call something else and pretend that
I
there's
see.
a magic cutoff at 18.
I see.
So there's a DSM, oh, I hope I don't get hate emails about this, but
I'm
disorders
sure you
of,
won't.
emotion dysregulation or something like that. Anyway, that it's like an emotion dysregulation disorder. And sometimes I think, why create an entirely different disorder
Yeah, it just
for
confuses
childhood?
people.
It just confuses people. And let's acknowledge that BPD doesn't just happen at age 18.
No, not at all. I know. And then there's people that I know that are 67 and getting diagnosed. And that breaks my heart because they've probably struggled for 60 years. And for many reasons, including stigma and lack of access, likely were never told what was going on. And now they can find their community. Now they can find peer support. But to take that away from someone just feels more unethical than being worried about the stigma that they might experience if they get labeled.
Exactly. I'm going to turn the tables and ask you a question just because I'm curious.
Sure. Yeah.
What are your thoughts about the name borderline personality disorder? Do you think that contributes to the stigma, or do you think that that's, if it were named something else, that might get stigmatized?
Yeah, I think changing the name isn't the solution to stigma, right? If the name was horrible person disorder, then sure, but it's not, right? Borderline is such a elusive term that really, unless you know the history of the name, it means nothing to people.
Right.
I have heard people say that people think borderline means like almost mentally ill, but not. But other than that, the name kind of means nothing in the grand scheme of things. So I think moving to like the ICD, emotion dysregulation disorder, something like that, or unstable. What is it in ICD?
I think it might be unstable.
Emotionally unstable personality disorder. I think that's more descriptive, which is more helpful. I also think that the stigma isn't going to fix itself overnight because of a name change, right? But I do also have some questions around the personality disorder label itself, because I think it implies this untreatability. And that is a huge component of stigma as well, and self-stigma, right? Just feeling like, well, if this is my personality disorder, there's no, or if this is my personality and I can't change it, then what's the point of trying to change?
Right.
There's so much longitudinal research now that not only is it super treatable, but also over time, it usually dissipates with age in a lot of ways. So it kind of, I think there's so many components to the name that cause stigma, but it's more about us trying to solve the stigma problem than change the name, if that makes sense.
Yeah. No, I agree with that. And I've seen similar campaigns with other disorders. And, one of the arguments is that it's not about the actual label. It's about the dialogue.
Exactly. Yeah. Yeah. I would welcome a name change. Don't get me wrong. I think the name borderline really doesn't mean anything at this point, but it won't solve the problem. And I think a lot of people want to change the name because it'll solve the problem. It would solve the problem of being conflated with bipolar disorder, which happens all the time and causes a lot of misunderstanding. So that would be helpful. But at the end of the day, I think it's kind of not my biggest battle cry,
Yeah. But your point about narcissistic personality disorder is a really good one, in the stigma that is experienced and how, therefore it prevents people from coming out and sharing their experiences for us to be able to learn about it and therefore treat it more effectively.
Yeah, so I'm really excited to learn about all of that. And there's also others that are going to Congress that I've interviewed for the podcast before. So Robert Gregory I've interviewed, Amanda Ulizik I've interviewed. So I'm so excited to see some of these people that I've never met in real life attend. So that'll be awesome. And there's also, for those who are interested in registering, there's a lived experience half-day workshop on day 1. I don't know. I doubt that's going to be part of the hybrid option because I don't know what room it's in.
I'm not exactly sure. I don't know that the workshops are being live
Right.
streamed, but
Okay.
if there were one, that would probably be the one
Okay.
to be live
And
streamed.
honestly, there's, I think, a lot of people that you'll know from social
Mm.
media going to that lived experience half day. And so they'll probably be filming content that people will be able to see online as well. But it's going to be such an exciting week. I unfortunately can't go to day one due to the travel issues, but I will be there for day 2 and 3. And Shirley, you'll be there the whole time.
Yep. Yes.
Awesome.
Yes.
Is there anything else you want people to know about the Congress before I ask my last question?
No, I hope that you can join us in Boston. I think the vibrancy of being in person, I think is definitely what makes conferences so special. And if you're there, come and say hello.
Amazing. Yeah, I'm so excited. I've never been to Boston before, so I've heard it's absolutely beautiful.
It's a beautiful city.
Yeah, and there's some members of the Super Feelers Club, which is the peer support group I run, that live there. So we're going to have a little dinner.
Wonderful.
And get to meet people. So I'm so excited about that too. And
that's great.
Maybe they'll come to the Congress. That would be great too.
Yeah, I hope so.
Okay, so my final question is usually, what do you love about having borderline personality disorder? But that's probably not relevant here. So what do you love most about studying suicide and working with youth who are struggling with non-suicidal self-injury and suicide? Great
question. I love that there's actually hope. Especially with teens. One of the things I love working with teens is it's not like they've heard it all before.
Right.
So I love that aspect. To me, I think that you see this, I think in teens and adults, but especially teens, suicide is sort of a crisis-driven behavior that especially in teens, there's less chronicity. And so I love being able to see people get through a crisis.
Right.
And be on the other side of it. And I feel like that engenders a lot of hope. And that's sort of, part of why we do what we do.
Amazing. Yeah. And they have a whole life ahead of them too, which is so exciting to be able to see them grow and see what they do next, which is
exactly
beautiful. Awesome.
Yeah.
Well, thank you so much, Shirley. I'm so excited to meet you in person in November.
Likewise. Thank you for having me.
Of course. Thanks for coming. I hope you have a wonderful afternoon.
Thank you. You as well.
Thank you so much for listening to the Super Feeler podcast. This episode was recorded on the traditional and unceded territory of the Matsqui and Sumas First Nations. If you'd like to learn more about the Super Feeler podcast, share your story, or participate in the Super Feelers Club, which is our peer support group, it's totally free, virtual, and open to anyone who experiences intense emotions or has borderline personality disorder, please check out the link in our show notes or go to laurieedmondson.com. If you would like to support the show, we would very much appreciate it. There's an option to do monthly small donations at whatever denomination you'd like, and you get bonus content, extra resources, and extra connection to me throughout. That can be found on patreon.com/superfeeler, or again in the notes below. Thanks again, and have a great day.